Okay, so we're moving into our second to last module for life support. And in this chapter, we're going to be talking about discontinuing ventilatory support or kind of that process for weaning from mechanical ventilation. So, this process is really just kind of covering that transfer of the work of breathing from the ventilator back to the patient. So in most cases, this is going to be accomplished pretty rapidly. Maybe you've witnessed that in your clinical settings where the patient's underlying condition has been corrected, and then we kind of rapidly wean them off the ventilator onto some more lower level oxygen therapy or support. In a couple patients, though, or a couple certain types of scenarios, um, patients, may become kind of vent dependent or not able to maintain that adequate ventilation, and that weaning processes can take a little bit longer. So, a couple of learning objectives I'm just going to click through real quick. Um, and, just kind of going through some background information again. Mechanical ventilation is used to support patients until that underlying condition is corrected. Okay. Um, so, we talked about this with initiation of ventilation is that ventilatory support doesn't fix the underlying problem. It just helps sustain the patient's life, takes over that work of breathing until that underlying cause can be corrected. We learned also about a lot of the complications and hazards with mechanical ventilation. So there's going to be cardiac, um, renal, hepatic, even CNS side effects that the patient's going to be at risk for when they are on mechanical ventilation. Another big thing patients are at risk for with mechanical ventilation is infection. Anytime we put a patient on any type of invasive support or invasive system, their risk for infection increases. So one of the best ways that we prevent like ventilator associated pneumonia is by getting the patient off the ventilator quickly. Um, with that in mind, every single patient that you see in the hospital, you should be constantly evaluating them for their ability to wean off that support. So every single time I go into a patient's room, I should be thinking about trying to wean something. Every time I see a patient, I'm going to be assessing to see if they can wean their oxygen needs, wean their PEEP, wean them off the machine so that we can get the tube out as quickly and safely as possible. Um, So the term vent dependent is a term that we use for patients who need ventilatory support for long periods of time. So 2 weeks or more typically, or they're not responding to any of our attempts to discontinue the ventilation. Um, so again, our main goal with whenever we put a patient on a ventilator is to try to get them off as quickly as possible. But we also want to minimize the risk for reintubation. So obviously hopefully you guys remember from airway management, there's a lot of complications that happen during that intubation process. We want to minimize those by not having to reintubate patients. So we want to be selective in who we're extubating. And there's certain criteria that we're going to go through later on this chapter to help with that. So, again, some of those delays in weaning or discontinuing the ventilator put those patients at risk for ventilatory complications like pneumonia, cardiovascular side effects, which could even include MIs and possible death from, not failure to wean. Excuse me. Your chapter talks about 3 main methods that we use for discontinuing ventilation. So there's not very much data out there that supports use of any of these techniques except for CPAP, which seems, to be a good process for discontinuing ventilation. But most of these other 3 main tactics, probably I feel like we see more often. Spontaneous breathing trials means taking the patient completely off the ventilator, putting them on like a T-piece, aerosol device, having them breathe completely on their own with just some flow and oxygenation there to support their oxygenation needs. So in some situations, I believe when I used to work at St. Joe's Milwaukee, one of the intensivists really preferred this method for weaning. So wanted that for all of his patients. Another method is using intermittent mandatory ventilation, so SIMV, as a way of weaning a patient. So if you're using that method, you're, obviously switching them to that mode, that partial support mode, and weaning down the set rate to gradually have the patient assume more of the work of breathing. And then what most of you probably are familiar with is those pressure support trials. So using pressure support plus CPAP plus a little bit of pressure support to help facilitate kind of the removal of that tube. There's also some alternate techniques. Again, these might be very site specific. Some sites use volume support ventilation, which is like pressure support, but you're kind of the patient triggers the breath, but they're still getting guaranteed volume. Adaptive support, automatic tube compensation, proportional assist ventilation, all of those are kind of adjustable support ventilation that help meet patient demand. NAVA, we've talked about as a neurologic assist adjusted vent support, where the patient has that catheter in their esophagus and it's measuring diaphragm activity, and that's how it's triggering the vent. So it's forcing the patient to use their diaphragm, and then just straight CPAP, which is also acceptable. So I would say it's important to just know that these methods are all acceptable methods of weaning. You might get any of the above as a choice on an MBRC question. When the patient's doing, you have evidence that the patient's doing well and you want to wean the patient, getting them ready for extubation. So any of these methods may be what the MBRC gives you as a choice. Okay, some general terminology to talk about. So weaning is that general term to refer to the process of discontinuing vent support. Okay, so this, like I said, every day our patient should be weaning. So it's not like a specific time frame. It's not like there's maybe not a general method involved, but when you're turning down any of the support mechanisms on the ventilator, you're technically weaning the patient. Vent discontinuation refers to the process of disconnecting the patient from the vent support. Discontinuing ventilatory aid is referring to that process of removing the patient from the ventilator, regardless of what method using. And this comes into play with, when we talk about terminal weaning, or the phrase terminal weaning, where you're taking the patient off the ventilator, even though you know that they're not going to sustain work or breathing on their own. That's discontinuing that vent support. So in general, patients are considered for removal from ventilator support if they fall into one of these 5 categories. So one being those whom removal is quick and routine. This is, again, the vast majority of our vented patients. A lot of our vented patients are post-surgical patients who needed the tube for surgery. Now that they're done with surgery, weaning should be quick and relatively painless. 2 are those who are more systemic approach to discontinuing of vent support. So this is about systematic approach. This is normally about 15 to 20% of the vented patients. So these might patients have maybe a little bit of complicated respiratory history. 3 are those patients who take days to weeks to wean from vent support. This is usually less than 5% of vented patients. Typically, most of your patients are going to be intubated for less than 3 days. If you're intubated more than a week, you're kind of falling into this smaller percentage of patient populations. So number 4 is your vent-dependent or unweanable patients, who compose less than 1% of the patients requiring vent support. So you guys, think about LTAC patients that go to long-term trach vet facilities. This is like 1% of all the patients who require vent support in the hospital are going to end up in places like that, where they're, have difficulty weaning them, or unweanable, and go home with ventilators. And then finally, the last category are those that are no chance of survival, or whom the ventilator is discontinued while comfort measures are provided. So these are terminal weans, considered those terminal wean patients. Okay. Vent workload and demand. Ventilatory workload is the amount of work that the respiratory muscles are used to perform and provide ventilation for the patient. So how much work the patient has on the ventilatory system is going to be dependent on things like the level of ventilation needed. So if my body's producing more CO2, I need to increase my ventilation to get rid of it. Obviously, the compliance of my lungs, by this point, you guys should know that as my compliance decreases, I'm needing to generate a bigger pressure gradient in order for that same volume to enter my lungs. So as my compliance decreases, my lungs have to work harder to make that bigger pressure gradient. Resistance, as my airway resistance increases, that is going to also require a bigger pressure gradient in order for flow to happen through those airways. And then finally, any mechanical factors that might impose a different impose work of breathing on the ventilatory system. Okay. So any of those can cause let me think, artificial airways are going to cause is going to be a mechanical factor that is going to increase the work of breathing. Obstructions, vent circuits, auto PEEP, any asynchronies, those are all those mechanical factors that are going to increase your work of breathing. So the level of ventilation required is determined by kind of the following things. That's, again, your metabolic rate. So how much CO2 you're producing, your central nervous system drive, how much your brain is telling your body to breathe, and that dead space that it has to overcome. So if I have a lot of dead space ventilation happening, the rest of my lungs are going to have to work that much harder to make sure that gas exchange is occurring. Okay, so you said that, your mechanical factors that are going to increase your work of breathing are those artificial airways, obstructions of the airway, vent circuitry, and those asynchronies like auto PEEP or low flows. Okay, so ventilatory capacity is determined again by that CNS drive. So ventilatory capacity is kind of how much work the lungs can do, or the ventilation system can do. So again, it's going to be determined by that drive, how much drive there is for me to breathe, how strong my respiratory muscles are, so how much of a gradient, pressure gradient that they can create, and then that endurance, like how long they can keep up the demand for a higher respiratory rate or that higher pressure. So muscle strength plays a big factor in the capacity. So muscle strength is going to be influenced obviously by age. Your extreme ages are going to have a harder time keeping up with their ventilatory capacity or reaching adequate ventilatory capacity. So the very young, very old, your preemies and your geriatric patients. Gender can play a role. Obviously, men have a little bit higher muscle mass than women do. Muscle bulk, overall health, and then things like malnutrition. We've talked about how important nutrition is for your body, for your critical care patients. if you need to be making sure that you're adequately supporting the nutrition needs of your patients to make sure that they have enough muscle strength, and energy, their body's producing enough energy to kind of come off the ventilator and, sustain their own work of breathing. Electrolyte imbalances also can have effects on the ventilatory system. So things like calcium, magnesium, potassium levels, phosphate levels, those if those are outside the normal range, that can cause ventilatory muscle weakness. Also, if your patient is um, on any medications in the ICU, like sedatives, neuromuscular blocking agents, that can also lead to muscle weakness. Okay. So the success of patients from liberation from vent support is going to be related to four main areas. The first of them is going to be the ventilatory load versus their capacity. So how much vent load is required from the patient versus how much they're capable of doing. Their oxygenation status, their cardiovascular function, and then psychological functions. So again, when vent workload or demand exceeds the capacity, that means that it's going to be very, very unlikely for the patient to become extubated. So things again that are going to increase your ventilatory workload are things like decreased compliance, increased resistance, and those mechanical factors. So all of those things are going to cause that ventilatory muscle fatigue and make it hard for the patient to come off the vent. All right. So I've already mentioned that careful patient assessment is required to determine which patients are ready to be removed for ventilatory support. There are a lot of weaning protocols that are out there that are very site specific, but they all kind of have the same theme where you're, evaluating the patient for the kind of the correction of those underlying causes, evaluating the patient to make sure that they have a spontaneous effort, that they're hemodynamically stable, that they have enough respiratory muscle strength in order to sustain that work of breathing on their own. So one of the important factors to consider as part of the assessment is the length of the time the patient's been on the vent. So in general, patients who've been on the vent for less than 72 hours can often be removed quickly. As I mentioned before, we usually have that 3-day window to get people off the vent successfully. And as they are on the ventilator longer than those 3 days, things become a little bit more complicated. So there's a nice box at the top of your page 1188, box 53.4, that just talks about factors associated with readiness to discontinue ventilation. So these are the things that I would kind of have in the back of my head when I'm looking at all my scenarios of, is the underlying cause been reversed? Do they have baseline good functioning status? Good oxygenation, good hemodynamics, functional status of all their other organs, short duration of ventilation. Okay, those are all going to be factors that help you that help identify patients that are going to be good for discontinuation or weaning from the vent support. So there's several other important criteria that help us determine that the patient's condition's improving. So one of them, like I said, the single most important one is that they've had the reversal of the underlying disease and condition. that their oxygen status is adequate. So things that help us to identify that we have adequate oxygenation might be, looking at our PaO2s greater than 60, making sure our FiO2 is less than 40 to 50%. Okay, this is significant because, we've talked about the fact that it's so important to have our oxygenation below 60%. But if I'm going to take you off the ventilator, I don't want you to be at 60% because I know once I remove you from the vent, I'm probably going to have to go up on your oxygenation. So if I'm already using 60%, I take you off the ventilator, I'm taking you off that keep CPAP type support. I know that you're not going to probably be able to maintain good oxygenation. So I want that oxygen status. Most weaning protocols that I know of want that FiO2 to be below 40% before you take the patient off the vent. So usually they want their FiO2 to be, less than 40, 50%. We want our PEEP to be less than 5 to 10. Okay. And then typically you might also be looking at PF criteria, which is not as commonly looked at, but we want it to be greater than 150 to 200. Okay. That one's not as I feel like significant, but these first three criteria are definitely significant in most of the protocols I'm aware of. So number 3 is is a patient medically and hemodynamically stable. So is there any marked hypotension is really what this is probably most related to. So you want to make sure that your patient has adequate blood pressures. A lot of times weaning protocols are that they're not on pressors. So they're not on things like dopamine or dobutamine to help them maintain that good blood pressure. There's sometimes that we will wean a patient even if they're on these medications, but it's only when the patient's on a very low dose of these meds. And then finally, can the patient spontaneously breathe? So they have to be able to breathe spontaneously in order to come off the ventilator. So if you have no spontaneous effort, you're not going to be attempting a weaning trial. Uh, so we don't want to just use clinical judgment. We want to use certain types of different weaning indices to make sure that our patient is ready for discontinuation. So there's several traditional indices that we might use. So one of them being the PF ratio. Another one might be your PAA gradient. Figuring out that's just, again, looking for adequate oxygenation. I think big ones are going to be these guys here: maximum inspiratory pressure, vital capacity. Those ones relate to respiratory muscle strength. So a MIP is that maximum inspiratory pressure, so that this is not patient effort dependent. So if I do a MIP on a patient, it's not effort dependent. I'm just going to be, essentially what I'm doing is I'm occluding the end of their endotracheal tube. So their endotracheal tube is completely blocked. The patient is going to make the maximum effort that they can against that pressure, that occlusion, and I'm going to just be reading the pressure that they're creating. So the more negative the number, the better it is. So a MIP of -20 would be adequate. A MIP of -30 would be better. A MIP of -10 is not good enough, does not demonstrate adequate enough muscle strength for the patient to be extubated. Vital capacity is a little bit trickier. We do this on all of our patients with extubation, but vital capacities are going to be dependent on the patient following directions and patient effort. So vital capacity, again, is that maximum inspiratory effort, maximum expiratory effort. Okay, so it's as much air as I can get into my lungs and then blow it all out. So that's going to be very much dependent on my patient's effort. If they're not able to follow commands, they're not really going to be able to give me accurate vital capacity. Spontaneous minute ventilation, this again is not patient dependent. So the patient is going to be switched over to like pressure support or spontaneous breathing trial, and then their spontaneous minute ventilation will be assessed. So obviously, if their minute ventilation is really high, that indicates that the patient might not do well or not be able to sustain that amount of effort after they get him off the ventilator. Maximum voluntary ventilation. This again tells us a lot about whether or not my patient has adequate like respiratory muscle endurance. Not always used in every vent weaning protocol, I would say. Some of the newer indices that are out there are things like your rapid shallow breathing index, which is just taking your frequency, dividing it by your tidal volume. And why this is an important index is because it really, again, demonstrates you could have a minute ventilation that's really high or seemingly in the right range, but if you're achieving that minute ventilation by breathing really, really fast and shallow, again, that probably indicates that your patient's not going to be able to sustain that level of ventilation post extubation or adequate gas exchange. So rapid shallow breathing index is usually a really important one. Airway occlusion pressure. This one's a little bit trickier. I feel like this one's not always highly used. It kind of indicates this is kind of the drop in that airway pressure during inspiration against an occluded airway. So it really helps us understand like respiratory muscle pressure and lung stress. So it helps kind of identify patients that have extremes in their respiratory muscle effort. And then just kind of any other identifier way that we look at work of breathing is important when we're looking at weaning a patient off the ventilator. So I feel like this is a very important like chart for you guys to kind of know. I would kind of have this, at least this first part of it, memorized. I think that these indices are the common ones that you're going to be asked to understand. So I would definitely kind of have that. That would be what I would make my flashcards off of for weaning indices. Okay. Right. So when we talk about oxygenation, poor oxygenation status is very closely associated with weaning failure. So you want to make sure that you have adequate oxygenation before discontinuation. So your PaO2 should be more than 60. You can lower that a little bit for your COPD patients. And your FiO2 should be lower than 40-50%. And we already talked about our PEEP and our PF ratio there. So it's just making sure that, we're not extubating our patients so soon that the second we take them off and they have to do more of this work of breathing and their oxygen need goes up, that we're already needing to go back to ventilation because we have no room to wiggle with our basic oxygen therapies. Acid-base balance. So when we're looking at our patients with acid-base balance issues, be especially careful of our patients who have any abnormalities that need to be corrected before weaning. So a big one is like if you have a patient that's in metabolic acidosis. So your ketoacidosis patients, diabetic ketoacidosis patients that come in with very, very low pHs, very low bicarbs because of all that extra fixed acid in their blood. And then they compensate by breathing really deep and really fast, which is that Kussmaul breathing. Well, that's not sustainable depending on the patient. Like if it's a very old patient or a very young patient, they're not going to be able to sustain that increased ventilatory needs for very long. So if I haven't corrected that metabolic acidosis, it's going to be very difficult for me to wean those patients because I can wean and extubate them and then, they can run into ventilatory fatigue rather quickly afterwards and need to be reintubated. So we want to make sure that that's corrected first. So patients with metabolic alkalosis or those who have been hyperventilated for several days, they might have that reduced ventilatory drive because the patient might think, their body's like adjusted to the new norm of having that lower CO2. So you want to be careful with these patients before just abruptly discontinuing ventilation. You might want to reduce your support gradually to help them kind of restore that acid-base balance before pulling the tube completely out. Other metabolic factors, big one we've talked about before is that excessive carbohydrate feeding. If the patient's on a high carb diet, that's going to increase that CO2 production. That means my patient has to ventilate much more efficiently to get rid of that excess amount of CO2. So we don't want to, we want to be careful that our nutrition is adequate enough to sustain respiratory muscle mass, but not so excessive that we're producing so much carbon dioxide that the metabolic rate increases. Also, that metabolic rate increases with things like fever or sepsis. So I'd be very hesitant to wean a patient who has a high fever or is actively sepsis. Things like renal function and electrolytes. We want to make sure that our patients have adequate renal function because that maintains our homeostasis, maintains our electrolyte concentrations and fluid balances. So we want to assess that our patient has adequate urine output before looking to extubate them, especially too if they're retaining that fluid that's causing weight gain, water retention, weight gain, or edema. Again, fluid retention also can result in things like congestive heart failure or pulmonary edema, which is going to make it much more difficult to have gas exchange. So we want to be careful with that. So adequate urine output is considered more than 1,000 milliliters per day. So you want to be kind of watching for that when you're looking at potentially extubating your patient. Assessing their cardiovascular function. So we need to make sure that we have good cardiac output so that we provide adequate blood flow to the lungs and then adequate oxygen delivery to the tissues. So we have to have an cardiac rate and rhythm and blood pressure should be evaluated. The presence of any arrhythmias, hypotension, hypertension should be assessed carefully before we decide to pull the breathing tube out. Any type of left ventricle dysfunction or MI or cardiovascular instability should be assessed for, and if it's present, we might want to not discontinue ventilation until those acute portions of that are kind of resolved. Okay. So some psychological factors or part of our CNS assessment of the patient should be that the patient is ideally awake and alert before we try to extubate them. So they should be free of seizures and able to follow commands. So typically I go in the room before I start my weaning trials, and I'm gonna, ask the patient to squeeze my fingers, open their eyes. Another big one that I like to do is see if they can lift their head up off the pillow, because not only does that assess to see if they can follow my commands, but that tells me a little bit about their upper airway strength, that if they're able to have enough strength in their muscles in their neck, that usually indicates to me that they have enough strength to kind of maintain their patent airway. So if you have a patient who has had strokes, excessive amounts of sedation, neuromuscular blocking agents, they're non-narcotic drugs, that can really impair their central neurologic controls of their ventilation. So you want to make sure that they're completely off those medications, and that those medications have kind of been had time to be processed out of their system before we attempt to extubate. So we do those sedation vacations with patients daily, but I will tell you that there are some patients who surprisingly, you can turn off the medication and everybody's body is going to be different, and they're going to process those meds differently. Some patients, even without drug histories, might be more susceptible to certain types of pain medications or sedation medication. It might take them a lot longer to kind of work those out of their system. So it might take a couple days for a patient to be awake and alert enough to be extubated, even after turning off that sedation. And that's why it's so important to work with our nursing partners along the way to make sure that our patients are receiving minimal amounts of sedation, the minimal amount of sedation required to keep them calm and comfortable on the ventilator. Another big factor with weaning and extubating is there's going to be a lot of potential fear, anxiety, pain, or stress with this process. Many patients might remember how they felt prior to being intubated, and all of the fear of feeling like that they couldn't breathe. That has to be so scary for them. So I try to be really, really reassuring when I'm doing my weaning trials. A lot of times I'll even start my patients a little bit higher on the pressure support. So when I switch them over, it's a lot easier for them initially, so that it's not like this big shock to their system where they're very, very anxious and concerned about trying the spontaneous breathing trial. I switch them over, and I'm only giving them 5 of pressure support, and that's really, really hard to breathe right out of the gates. And then that just ramps their anxiety up and causes them to breathe really, really fast and really, really shallow, and then they ultimately fail. So a lot of times one of the best recommendations I can give you guys is to spend a lot of time in the room with your patients when they're at least starting out with their weaning, and making sure that they're comfortable and they're not and you're managing that anxiety portion of it. So, being with them, being patient, reassuring them that if it becomes difficult, that you'll switch them back on the ventilator, and that you've got their breathing supported if need be. Okay. Patients' families can also be very helpful. Another thing I just have to say is, don't switch somebody to pressure support and leave the unit. Minimize that as much as possible. I like to, be in you're not obviously can't be in the room for 30 minutes, but I like to be around in the vicinity of my patients that are on pressure support trials, so I can peek in, double check on them, make sure that they're comfortable still, and that we're catching them early on in that if they're failing that weaning trial, rather than waiting until they crash and burn and their vitals change before we switch them back. So your book talks about other factors that are associated with discontinuing success. So these integrated indices can be used to improve prediction by combining several measures about the ability to breathe without vent support. So some examples are the CROP score, which is combined measures like vent workload, respiratory muscle strength, and gas exchange. There's the adverse factor ventilatory score, which combines like 15 different factors like hemodynamic values, infections, nutrition, FiO2 compliance, minute ventilation, things like that. There's a weaning index, which combines measures of strength, endurance, and efficiency of gas exchange. So weaning index of less than 4 usually indicates successful discontinuation. So the lower the number, you're better with that. And then finally, your Burns weaning assessment program. This is like 26 different items. And, 12 of them are general, 14 of them are respiratory factors, and that kind of combines them into a single score. Okay. So it's important to understand too, there's a difference between the decision to discontinue vent support and the decision to extubate. So some patients can be successfully removed from the ventilator, but still shouldn't be extubated. That's due to upper airway issues. So these patients would be, indicate that they might need a tracheostomy. So some examples of this might be, you've had a patient that's been intubated because they weren't able to protect their airway. And due to like upper airway swelling or something like that. They might not need the ventilator, but they still need that ET tube, because if they pull the ET tube out, the swelling in their airway will close their airway off again, and you'll wind up in the same boat where they don't have a patent airway and they need to be reintubated. So tracheostomies in those types of situations can improve that patient comfort, allow for effective suctioning, decrease that airway resistance because we're shortening the airway, enhance the patient's mobility because they're not needing to be on the ventilator. They can eat and they speak. So those are all benefits. A lot of times we look to see if their airway is patent when they're still intubated by doing what's called a leak test, where I'm deflating the cuff around the ET tube and I'm listening for that air leak. So if you think about it, everybody, when we deflate the cuff around their cuff in their ET tube, we should hear a big leak. We should hear air and gurgling and a big leak. A lot of times you guys have probably heard this at clinicals where the cuff is not inflated enough and you can hear the gurgling from the door. If I don't hear any leak at all, that tells me that that airway is swollen around that ET tube and that patient should not be extubated. So a lot of times we do those air leak tests to see if there's airway edema. The patient then could be treated with steroids if they notice a lot of edema, to see if we can get that swelling down. But, obviously tracheing the patient might be another option just to facilitate getting them off the ventilator. Right. And I think that is where I am going to stop this lecture, and I'm going to pick up with preparing the patient in lecture 2.